Do you want to successfully complete the C790 Objective Assessment Exam? Then you are in the right place. Our website provides a list of questions and answers for your success in the C790 OA exam for free. We understand that acing your OA exam can be quite challenging. That's why we provide completely free exam guides and practice questions for you. In this video, we will cover questions from project management, system implementation, testing methods, terminology standards, and system analysis. So, let's get started. 1. A hospital is selecting a project management tool to track task dependencies and milestones for their new electronic health record implementation. Which visualization tool would be most appropriate for displaying the project timeline with overlapping tasks and critical deadlines? A. Work breakdown structure. B. RACI matrix. C. Gantt chart. D. Fishbone diagram. Can you guess the answer? Correct answer, C. Gantt chart. Explanation. Option C is correct because Gantt charts are visual timelines specifically designed to depict tasks, durations, dependencies, and milestones, making them ideal for project scheduling and tracking progress over time. Option A is incorrect because work breakdown structures hierarchically decompose project scope into work packages, but do not show timeline or dependencies visually like Gantt charts. Option B is incorrect because RACI matrices assign responsibilities for tasks, but do not provide visual timeline information or show task dependencies and duration over time. Option D is incorrect because fishbone diagrams are root cause analysis tools used to identify potential causes of problems, not for scheduling or tracking project timelines. Alright, let's break down the core concept behind this question. When managing a complex health IT project, like an EHR implementation, you need a tool that shows you the big picture of your timeline, while also revealing how tasks connect and depend on each other. That's where Gantt charts come in. They're visual timelines that display tasks, their durations, the dependencies between activities, and critical milestones all in one place. Think of it like a roadmap showing not just where you're going, but also which roads must be travelled first before others open up. Work breakdown structures are great for organising tasks hierarchically, but they don't show time or dependencies visually. RACI matrices tell you who's responsible for what, but they don't give you timeline information. And fishbone diagrams are for finding the root cause of problems, not for scheduling work over time. 2. During the analysis phase of implementing a clinical information system, a healthcare organisation needs to understand current workflows and identify inefficiencies. Which tool would best help visualize how patient data moves through different departments and identify bottlenecks? A. Project charter. B. Data flow diagram. C. Network diagram. D. Cost-benefit analysis. Do you know the answer? Correct answer, B. Data flow diagram. Explanation. Option B is correct because data flow diagrams visually map how information moves through systems and processes, making them essential analysis tools for understanding current workflows and identifying gaps or inefficiencies. Option A is incorrect because project charters formally authorize projects and outline objectives and scope, but do not visualize workflows or data movement through organizational processes. Option C is incorrect because network diagrams map project tasks and dependencies for scheduling purposes, not data movement through clinical workflows or departmental information exchange. Option D is incorrect because cost-benefit analysis compares financial costs and benefits of investments, but does not visualize workflows or show how data moves through departments. Let's explore the theory behind analyzing healthcare workflows. During the analysis phase, organizations need to understand how information currently moves through their system before they can improve it. Imagine trying to fix traffic congestion without first understanding where cars are going and where they're getting stuck. Data flow diagrams are specifically designed to map exactly that. They show how patient information travels from one department to another, where it gets processed, and where bottlenecks occur. They're like GPS maps for your data. Project charters are important documents that authorize projects and define scope, but they don't visualize workflows. Network diagrams are for project task scheduling and dependencies, not for mapping how data moves through clinical processes. Cost-benefit analysis helps you understand financial impacts, but it won't show you the step-by-step journey of patient information through your organization. 3. A healthcare system is preparing to deploy a new electronic prescribing module across multiple hospitals. The implementation team decides to launch the system in one hospital first, evaluate results, then gradually expand to other facilities. What implementation approach are they using? A. Big Bang implementation. B. Waterfall implementation. C. Phased implementation. D. Parallel implementation. Can you guess the answer? Correct answer, C. Phased implementation. Explanation. Option C is correct because phased implementation involves incremental rollout to different units or departments, allowing organizations to test and refine the system before full deployment across all facilities. Option A is incorrect because Big Bang implementation involves simultaneous deployment across all units at once, rather than the gradual, incremental approach described in the scenario. Option B is incorrect because waterfall implementation is a sequential development methodology, not a deployment strategy, and refers to completing phases one after another during development. Option D is incorrect because parallel implementation runs old and new systems concurrently until full transition, rather than gradually rolling out to different locations over time. To really understand why phased implementation is the correct choice, let's dive into the theory of deployment strategies. When rolling out a major health IT system like electronic prescribing, organizations face a critical decision about timing and risk management. Phased implementation is like testing the waters before diving in. You implement in one location first, learn from that experience, fix any problems, and then gradually expand to other facilities. This approach minimizes risk because if something goes wrong, it only affects one hospital, not your entire health system. Big Bang would launch everywhere simultaneously, which is high risk. Waterfall is a development methodology about how you build software, not how you deploy it. Parallel implementation means running both old and new systems at the same time until transition is complete, which is different from the gradual location-by-location rollout described in the scenario. 4. In project management, a healthcare informatics specialist needs to clarify who is responsible for creating training materials, who must approve them, who should be consulted, and who needs to be informed. Which project management tool would best document these role assignments? A. Critical path method. B. RACI matrix. C. Gantt chart. D. Work breakdown structure. Do you know the answer? Correct answer, B. RACI matrix. Explanation. Option B is correct because RACI matrices are responsibility assignment charts that clearly indicate who is responsible, accountable, consulted, and informed for each task, ensuring clarity in role assignments. Option A is incorrect because critical path method identifies essential tasks that determine project duration and focuses on scheduling dependencies, not on assigning responsibilities to team members. Option C is incorrect because Gantt charts display project timelines and task durations, but do not specify detailed role assignments or clarify accountability for specific deliverables. Option D is incorrect because work breakdown structures decompose project scope into manageable work packages, but do not assign specific responsibilities or clarify stakeholder communication roles. This is a critical concept for project management. So let's dig into the principle behind responsibility assignment. When you're coordinating a complex project like healthcare IT implementation, confusion about roles can derail everything. Who actually does the work? Who has final say? Who needs to give input? Who just needs to be kept in the loop? The RACI matrix solves this puzzle by clearly defining 4 roles for every task. Responsible means you do the work. Accountable means you have final authority and sign-off. Consulted means your input is needed. And informed means you need to be updated on progress. It's like assigning positions on a sports team. Everyone knows their role. Critical path method finds tasks that determine project duration. Gantt charts show timelines visually. Work breakdown structures. Organize work into packages. None of these clarify who does what. 5. A hospital is evaluating whether to proceed with a major health information technology project. They need to assess if the expected benefits justify the costs over time and determine when the investment will break even. Which financial analysis method should they use? A. Gap analysis. B. Feasibility study. C. Net present value. D. Workflow analysis. Can you guess the answer? Correct answer, C. Net present value. Explanation: option C is correct because net present value calculates the present value of dollar benefits and costs of an investment, helping organizations determine financial viability and identify the break-even point. Option A is incorrect because gap analysis identifies discrepancies between current capabilities and future needs, focusing on functional requirements rather than financial justification or return on investment. Option B is incorrect because feasibility studies broadly assess project viability across multiple dimensions, but net present value specifically quantifies financial benefits versus costs over time. Option D is incorrect because workflow analysis examines process flows and task sequences to identify inefficiencies, not financial returns or cost-benefit calculations for investment decisions. All right, let's break down the financial analysis concepts behind this question. Before investing millions in health IT, hospitals need to know if it's worth it financially. Net present value is the gold standard for this analysis because it considers the time value of money. $1 today is worth more than $1 5 years from now. NPV calculates the present value of all future benefits and costs, helping you see if the project will actually generate positive returns and when you'll break even. Think of it as looking into a financial crystal ball. Gap analysis identifies functional differences between current and desired states, not financial returns. Feasibility studies are broader evaluations covering many factors, but NPV specifically quantifies the financial equation. Workflow analysis examines processes and efficiency, not dollars and cents of return on investment. 6. During the planning phase of an electronic health record implementation, stakeholders from clinical, technical, and administrative areas must be identified and their communication needs documented. What type of document formally authorizes the project and outlines these key elements? A. Request for proposal. B. System vision document. C. Project charter. D. Functional specification. Do you know the answer? Correct answer, C. Project charter. Explanation: option C is correct because project charters formally authorize projects and outline objectives. Scope: key stakeholders, roles, budget, timelines, and success criteria, establishing the foundation for project execution. Option A is incorrect because requests for proposals solicit vendor solutions and proposals, but do not formally authorize projects or define internal stakeholder roles and responsibilities. Option B is incorrect because system vision documents define scope and capabilities of new systems, but do not formally authorize projects or specify budget and timeline parameters. Option D is incorrect because functional specifications detail system requirements and features but do not formally authorize projects or identify key stakeholders and their communication needs. Let's dive into the critical planning documents that launch healthcare IT projects. Every major project needs formal authorization and a clear roadmap, and that's exactly what a project charter provides. Think of it as the project's birth certificate and constitution rolled into one. It formally authorizes the project to exist and establishes the ground rules for how it will operate. The project charter spells out the objectives and scope, so everyone knows what they're building and what's out of bounds. It identifies all key stakeholders from clinical, technical, and administrative areas and defines their roles. It sets the budget boundaries and timeline expectations. And it defines what success looks like with clear criteria. Requests for proposals go out to vendors to solicit their solutions. System vision documents define what capabilities the new system needs. Functional specifications detail technical requirements, but only the project charter provides that formal authorization and comprehensive stakeholder framework. 7. A clinical informatics team is designing a new patient portal that must be accessible to users with visual, auditory, and motor impairments. Which accessibility standard should guide their design to ensure legal compliance and inclusive access? A. HIPAA Security Rule. B. Americans with Disabilities Act. C. HITECH Act. D. Meaningful Use Standards. Can you guess the answer? Correct answer, B. Americans with Disabilities Act. Explanation. Option B is correct because the Americans with Disabilities Act establishes standards for accessibility, requiring health information technology systems to accommodate users with visual, auditory, and motor impairments through assistive technologies. Option A is incorrect because HIPAA Security Rule focuses on protecting confidentiality and security of health information, not on ensuring accessibility for users with disabilities. Option C is incorrect because HITECH Act promotes health information technology adoption and meaningful use, but does not specifically establish accessibility standards for users with disabilities. Option D is incorrect because meaningful use standards focus on demonstrating effective use of electronic health records for quality improvement, not specifically on accessibility for disabled users. This is about understanding legal requirements for inclusive technology design. The Americans with Disabilities Act is landmark civil rights legislation that requires equal access for people with disabilities in all areas of public life, including digital spaces and health information technology. When designing a patient portal, ADA compliance means ensuring someone with visual impairment can use screen readers to navigate it. Someone with hearing loss can access video content through captions, and someone with motor impairments can use keyboard navigation instead of requiring precise mouse movements. Think of it as building ramps and automatic doors for the digital world. HIPAA Security Rule is about protecting patient data confidentiality and security, not accessibility for disabilities. HITECH Act promoted health IT adoption and meaningful use incentives. Meaningful use standards focus on demonstrating effective EHR use for quality improvement. Only ADA specifically addresses accessibility for people with disabilities. 8. In the design phase of system development, a healthcare organization needs to create a working model of their new clinical documentation system for user testing and feedback before full development. What should the team create for this purpose? A. Data flow diagram. B. Configuration document. C. Prototype. D. Request for information. Do you know the answer? Correct answer, C. Prototype. Explanation. Option C is correct because prototypes are working models created for usability testing and validation, allowing organizations to gather user feedback and refine system design before committing to full development. Option A is incorrect because data flow diagrams visually represent how information moves through systems, but are analysis tools, not interactive working models for user testing. Option B is incorrect because configuration documents detail system settings and specifications, but are not interactive working models that users can test and provide feedback on. Option D is incorrect because requests for information gather information from vendors about available solutions, but are not working models created for user testing and validation. Let's explore what happens in the design phase when you need user feedback before committing to full development. A prototype is essentially a working model or mock-up of your system that users can actually interact with and test. Think of it like a car manufacturer building a concept car. It's functional enough to drive and evaluate, but it's not the final production model. Prototypes let you put something tangible in front of clinicians and staff so they can click through screens, test workflows, and give you honest feedback about what works and what doesn't. This saves enormous time and money because you can fix problems in the prototype stage rather than after you've built the entire system. Data flow diagrams are static documents showing information flow, not interactive models. Configuration documents specify system settings on paper. Requests for information gather vendor details. Only prototypes give users something they can actually use and test. 9. A health system is implementing an agile development approach for a new clinical analytics platform. They organize work into short cycles where the team is protected from outside distractions to complete defined goals. What is this time-controlled mini-project called? A. Sprint. B. Iteration. C. Phase. D. Milestone. Can you guess the answer? Correct answer, A. Sprint. Explanation: Option A is correct because sprints are time-controlled mini-projects in agile methodologies, specifically in Scrum, where teams focus intensely on completing defined goals without outside distractions during the sprint duration. Option B is incorrect because while iteration is a general term for repeating development cycles, sprint is the specific term used in Scrum methodology for these time-boxed periods. Option C is incorrect because phases are broader stages of the system's development lifecycle that contain multiple activities, not the short focus work periods characteristic of Agile. Option D is incorrect because milestones are significant events or decision points in project timelines, not the time-controlled work periods where teams complete incremental development goals. To really understand Agile methodology, let's break down how Scrum organizes work. In traditional project management, you might plan for months before seeing results. Scrum flips that by using sprints. These are time-boxed work periods, usually 2 to 4 weeks long, where the team commits to completing specific goals. During a sprint, the team is essentially in a protected bubble. No new requirements or distractions from outside. They focus intensely on their committed work, meet daily to coordinate, and at the end they deliver working software that can actually be used or demonstrated. It's like a basketball team practicing intensively for 2 weeks before a game, with no interruptions from outside. Iteration is a general term for repeating cycles, but sprint is the specific Scrum term. Phases are broader SDLC stages containing many activities. Milestones are decision points in timelines. Only sprint captures that time-boxed, protected, intensive work period that's fundamental to Scrum. 10. Before deploying a new medication ordering system, a hospital conducts testing with real patient data in a live environment to validate usability and performance with actual end users. What type of acceptance testing are they performing? A. Unit testing. B. Integration testing. C. Alpha testing. D. Beta testing. Do you know the answer? Correct answer, D. Beta testing. Explanation: Option D is correct because beta testing uses real data in live environments with actual end users to validate system usability and performance before full deployment, providing realistic validation of system readiness. Option A is incorrect because unit testing validates individual components or modules in isolation, not complete system performance with real patient data in live clinical environments. Option B is incorrect because integration testing assesses how different system modules work together, but typically does not involve real patient data or actual end users in production. Option C is incorrect because alpha testing uses simulated data rather than real patient data and occurs earlier in the testing process than beta testing with live users. Let's break down the different types of testing in health IT implementation. Testing is all about validation, making sure the system actually works before you put it in front of real patients. There are different levels of testing, each serving a specific purpose. Beta testing is the final validation phase where you use real patient data and real end users in a live environment to see how the system performs under actual clinical conditions. It's like a dress rehearsal with the actual cast and real costumes before opening night. This is different from unit testing, which only validates individual components in isolation, testing one puzzle piece at a time. Integration testing checks if those pieces fit together correctly. Alpha testing also tests the complete system, but it uses simulated test data, not real patient information. Beta testing is that crucial final step where rubber meets road with actual users and actual data. 11. A healthcare organisation uses C790 CT to document clinical findings in their electronic health record. When comparing C790 CT to ICD coding, what is the primary difference in how codes are assigned and viewed by end users? A. C790 CT requires manual coding. B. C790 CT coding is automated. C. C790 CT has fewer codes. D. C790 CT is less specific. Can you guess the answer? Correct answer, B. C790 CT coding is automated. Explanation. Option B is correct because C790 CT coding is always automated, with end users unable to view the codes assigned by the system, while ICD coding requires human intervention to assign or validate. Option A is incorrect because C790 CT utilizes automated encoding through applications and natural language processing, eliminating the need for manual code assignment by end users or coders. Option C is incorrect because C790 CT actually contains more codes than ICD, with over 100,000 concepts for clinical findings alone, compared to 68,000 diagnosis codes. Option D is incorrect because C790 CT is generally more specific and granular than ICD coding, providing greater detail for rare diseases and complex clinical expressions and concepts. This question gets at a fundamental difference between two major clinical terminology systems. When it comes to clinical documentation, C790 CT and ICD serve different purposes with different workflows. The key distinction is in how codes are assigned. C790 CT uses automated encoding through natural language processing and sophisticated algorithms. When a clinician types a clinical finding into the EHR, the system automatically assigns the appropriate C790 code in the background without the clinician ever seeing it. The clinician just documents in plain language, and C790 does its work behind the scenes. It's like your phone's autocorrect. It happens automatically. In contrast, ICD coding requires a human coder to review documentation and manually assign or validate codes, often after the patient encounter is complete. C790 CT actually has far more codes than ICD, not fewer, and is more specific with greater granularity. The automation versus manual coding is what truly sets them apart. 12. A hospital quality improvement team needs to standardize how laboratory test results and clinical observations are documented and exchanged across different health information systems. Which terminology standard should they implement for this specific purpose? A. C790 CT, B. LOINC, C. ICD-10, D. RACI. Do you know the answer? Correct answer, B. LOINC. Explanation. Option B is correct because LOINC is specifically designed as a standardized coding system for laboratory tests and clinical measures, containing over 80,000 terms widely adopted for ordering and exchanging observations. Option A is incorrect because while S-gnomed CT is comprehensive for clinical documentation, LOINC is specifically designed for laboratory and clinical observations and is the standard for this purpose. Option C is incorrect because ICD-10 is a clinical classification system designed for diagnoses and procedures used primarily for reimbursement and reporting, not laboratory test identification. Option D is incorrect because RxNorm is a normalized drug naming system for medications, including ingredients, strength, and dose, not for laboratory tests and clinical observations. Alright, let's dig into healthcare data standards and their specific purposes. The challenge in healthcare is that different systems need to communicate about the same things using the same language. When it comes to laboratory tests and clinical observations, things like blood glucose levels, vital signs, or microbiology results, LOINC is the universal standard. It was specifically designed to standardize how we identify and exchange these measurements across different health information systems. LOINC contains over 80,000 terms and uses a 6-part axis system to precisely identify each test: what you're measuring, what property, the timing, the specimen type, the scale, and optionally, the method. It's widely adopted and built into HL7 messaging standards. While S-gnomed CT is comprehensive for general clinical documentation, LOINC is the specialist for laboratory and observational data. ICD is for diagnoses and billing. RxNorm is for medications. LOINC owns the laboratory and clinical observation space. 13. During system implementation, clinical staff express frustration that they receive too many alerts when prescribing medications, causing them to ignore important warnings. What phenomenon is the implementation team observing, and what adjustment should they make? A. Scope: creep leading to reduced features. B. Alert fatigue requiring alert refinement. C. Workflow disruption, needing parallel implementation. D. Iatrogenesis requiring system shutdown. Can you guess the answer? Correct answer: B. Alert fatigue requiring alert refinement. Explanation: option B is correct because alert fatigue occurs when excessive alerts, often false positives or non-clinically specific warnings, cause clinicians to ignore important notifications, requiring refinement to reduce unnecessary alerts. Option A is incorrect because scope creep involves unplanned changes, expanding project scope during implementation, not the overuse of clinical decision support alerts causing clinician desensitization. Option C is incorrect because workflow disruption is a general term for interruptions to clinical processes, not the specific phenomenon of clinicians ignoring alerts due to overuse. Option D is incorrect because iatrogenesis refers to patient harm from health information technology errors, not specifically the desensitization to alerts from overuse requiring system refinement. Let's explore a critical challenge in clinical decision support implementation called alert fatigue. Imagine you're a physician trying to prescribe medications, and the system keeps interrupting you with alerts. Drug interaction warnings, duplicate therapy alerts, allergy checks. Most of these alerts aren't clinically relevant to your specific patient or turn out to be false positives. After seeing dozens of these in a day, you start clicking through them automatically, without reading them, kind of like how you might ignore car alarms in a parking lot because they go off so often for non-emergencies. That's alert fatigue. When excessive, non-specific alerts cause clinicians to become desensitized and ignore them, including the truly important ones. The solution isn't to remove alerts entirely, but to refine them so only clinically significant, patient-specific warnings appear. Scope creep is about project requirements expanding. Workflow disruption is general process interruption. iatrogenesis is patient harm from health IT, but alert fatigue specifically describes this desensitization phenomenon. 14. A research hospital wants to enable seamless exchange of clinical data, administrative information, and public health reports across different electronic health record systems using modern web-based standards. Which Health Level 7 standard is specifically designed for this purpose? A. Clinical Document Architecture. B. Digital Imaging Communications. C. Fast Health Interoperability Resources. D. Systematized Nomenclature. Do you know the answer? Correct answer, C. Fast Health Interoperability Resources. Explanation. Option C is correct because Fast Health Interoperability Resources, known as EFA, is specifically designed to enable exchange of clinical, healthcare administrative, public health, and research data using modern web-based standards. Option A is incorrect because Clinical Document Architecture is used to exchange specific documents like discharge summaries and assessments, not the broader range of data types FHR supports. Option B is incorrect because digital imaging and communications in medicine provide standards for sharing digital medical images, not the comprehensive clinical and administrative data exchange FHR enables. Option D is incorrect because systematized nomenclature of medicine is a clinical terminology for documentation, not a data exchange framework like EFA for interoperability between systems. This is about understanding modern interoperability standards in healthcare. Health Level 7 has been the backbone of health data exchange for decades, but healthcare IT has evolved and needed more modern, flexible standards. That's where HEFA comes in. Fast Healthcare Interoperability Resources. FGR was specifically designed to enable seamless exchange of clinical data, administrative information, public health reports, and research data using modern web-based standards like REST APIs and JSON. Think of it as bringing healthcare data exchange into the smartphone era. It's built on the same technologies that let your mobile apps talk to each other. Clinical document architecture is valuable but focuses specifically on document exchange, like discharge summaries. DICOM is for medical images only. S-nomed CT is a terminology for clinical concepts, not an exchange framework, for is the comprehensive modern standard for diverse data exchange. 15. A healthcare organisation adopts the Project Management Body of Knowledge framework for their health information technology initiatives. How many knowledge areas does PMBOK define to guide comprehensive project management across all aspects of projects? A. 5 knowledge areas. B. 7 knowledge areas. C. 10 knowledge areas. D. 12 knowledge areas. Can you guess the answer? Correct answer, C. 10 knowledge areas. Explanation. Option C is correct because PMBOK defines 10 knowledge areas including integration, scope, time, cost, quality, human resources, communication, risk, procurement, and stakeholder management to guide comprehensive project oversight. Option A is incorrect because PMBOK defines 10 knowledge areas, not 5, to ensure comprehensive coverage of all aspects necessary for successful project management in healthcare settings. Option B is incorrect because PMBOK encompasses 10 knowledge areas to provide complete project management guidance, not 7, covering everything from integration to stakeholder management comprehensively. Option D is incorrect because while PMBOK is comprehensive, it defines exactly 10 knowledge areas, not 12, to guide project managers through all essential dimensions of projects. Let's break down the comprehensive framework that PMBOK provides for project management. The Project Management Body of Knowledge, created by the Project Management Institute, serves as the definitive guide for project management professionals worldwide. It organises all the essential aspects of managing projects into 10 knowledge areas. Think of these as 10 different lenses through which you need to view and manage your project. These 10 areas are project integration management, which ties everything together, scope management, which defines what's in and out, time management for scheduling, cost management for budgets, quality management for standards, human resources management for your team, communication management for stakeholder interaction, risk management for threats and opportunities, procurement management for vendor relationships, and stakeholder management for identifying and engaging everyone affected. Together, these 10 areas ensure nothing falls through the cracks. Not 5, not 7, not 12. Exactly 10 knowledge areas covering the full spectrum of project management responsibilities. 16. In the Unified Process Development methodology, which phase focuses on defining the vision, describing all requirements, finalizing scope, and resolving high risks while producing realistic estimates for cost and schedule? A. Inception phase. B. Elaboration phase. C. Construction phase. D. Transition phase. Do you know the answer? Correct answer, B. Elaboration phase. Explanation. Option B is correct because the elaboration phase defines the vision, identifies and describes all requirements, finalizes scope, designs core architecture, resolves high risks, and produces realistic cost and schedule estimates. Option A is incorrect because the inception phase develops approximate system versions, makes business cases, and defines scope with rough estimates, but does not finalize all requirements comprehensively. Option C is incorrect because the construction phase iteratively implements remaining lower risk elements and prepares for deployment, rather than defining requirements and resolving high risks up front. Option D is incorrect because the transition phase completes beta testing and deployment so users have working systems, not the requirements definition and risk resolution characteristic of elaboration. To understand Unified Process Development methodology, we need to explore its 4 distinct phases and what happens in each. Unified Process divides projects into inception, elaboration, construction, and transition. The elaboration phase is where the heavy lifting of requirements and architecture happens. During elaboration, you move beyond the rough approximations of inception to really define the vision in detail, identify and describe all requirements comprehensively, finalize exactly what's in scope and what's not, design and implement the core architecture and critical functions, resolve all high-risk items that could derail the project, and produce realistic cost and schedule estimates based on this solid understanding. Think of it like an architect finalizing blueprints after the initial sketches. Everything gets detailed and validated. Inception is the initial rough vision. Construction builds the remaining low-risk elements. Transition is deployment and beta testing. But elaboration is where requirements crystallize and architecture solidifies. 17. A hospital pharmacy wants to normalize drug naming across multiple medication databases and terminologies to ensure consistent prescribing. Which standardized terminology system should they implement that derives information from multiple drug naming sources? A. LOINC. B. C790 C. RxNorm. D. ICD-10-CM. Can you guess the answer? Correct answer, C. RxNorm. Explanation. Option C is correct because RxNorm is a normalized drug naming system derived from 15 drug terminologies containing drug names, ingredients, strength, and dose to ensure consistent medication identification across systems. Option A is incorrect because LOINC is designed for laboratory tests and clinical observations, not for normalizing drug names and medication information across different pharmacy and prescribing systems. Option B is incorrect because while C790 includes medications in its comprehensive clinical terminology, RxNorm is specifically designed for normalized drug naming across multiple medication databases. Option D is incorrect because ICD-10-CM is a clinical classification system for diagnoses and procedures used for reporting and reimbursement, not for drug naming standardization. This question explores healthcare data standards for medication management. The challenge with medications is that different systems, pharmacies, and databases call the same drug by different names: brand names, generic names, various strengths and formulations. RxNorm was created by the National Library of Medicine to solve this chaos by normalizing drug naming across systems. It's derived from 15 different drug terminologies and vocabularies, bringing them all together into one unified system that includes drug names, active ingredients, strengths, and dose forms. RxNorm contains sources like the FDA National Drug Code, Micromedex, and Veterans Administration files. When a hospital implements RxNorm, a prescription for the same medication will be recognized the same way whether it comes from the pharmacy system, the EHR, or an external prescription. LOINC is for laboratory tests, not drugs. C790 CT includes medications but isn't specifically designed for drug name normalization. ICD is for diagnoses and procedures. RxNorm is the specialist for medication standardization. 18. During electronic health record implementation, a healthcare organization establishes experienced clinicians who receive advanced training to provide frontline assistance and support to their peers during and after the go-live period. What role are these individuals fulfilling? A. Implementation committee members. B. Project managers. C. Super users. D. Vendor representatives. Do you know the answer? Correct answer, C. Super users. Explanation: option C is correct because super users are experienced clinicians who receive advanced training to provide frontline assistance during go-live and ongoing support, helping their peers adapt to new systems effectively. Option A is incorrect because implementation committee members oversee strategic decisions and stakeholder communication at a higher level, rather than providing direct frontline clinical support to peers. Option B is incorrect because project managers coordinate overall project execution and resources, not provide direct peer-to-peer clinical support and training during go-live periods. Option D is incorrect because vendor representatives provide product expertise and technical support from the vendor organisation, not peer-to-peer clinical support from within the healthcare organisation. Let's dig into the critical human resources aspect of health IT implementation. When you're rolling out a major system like an EHR, you can't just rely on the vendor's support team or your IT department to help thousands of staff members. You need frontline clinical champions who understand both the clinical workflows and the new technology. That's where super users come in. These are experienced clinicians, nurses, physicians, pharmacists, who receive intensive, advanced training on the new system before everyone else. During go-live, they're embedded right on the units, at the elbow of their colleagues, providing immediate help when someone gets stuck or confused. After go-live, they continue as ongoing resources for questions and troubleshooting. Implementation committee members oversee strategy from above. Project managers coordinate the overall project. Vendor representatives provide product expertise but aren't clinicians who understand your specific workflows. Super users are that crucial bridge between technology and clinical practice. 19. A healthcare quality analyst needs to retrieve and analyse data about causes of mortality and morbidity at the national level for public health reporting. Which clinical classification system would be most efficient for this general reporting purpose? A. C790 CT, B. LOINC, C. ICD-10, D. RxNorm. Can you guess the answer? Correct answer, C. ICD-10. Explanation: option C is correct because ICD-10 is designed specifically for general reporting purposes, including mortality and morbidity statistics, public health surveillance, and administrative performance monitoring at national levels. Option A is incorrect because while C790 CT provides greater clinical specificity, ICD-10 is more efficient for general national reporting of mortality and morbidity causes for public health. Option B is incorrect because LOINC is designed for laboratory tests and clinical observations documentation and exchange, not for mortality and morbidity classification and reporting at national levels. Option D is incorrect because RxNorm normalizes drug naming across medication systems, but is not used for reporting causes of mortality and morbidity at population or national levels. This question is about matching the right classification system to the right purpose. In healthcare informatics, different coding systems serve different needs. ICD-10 is specifically designed as an output system for general reporting purposes. It's optimized for collecting population-level statistics about mortality and morbidity causes, supporting public health surveillance, tracking disease trends at national and international levels, and supporting administrative functions. The World Health Organization maintains ICD precisely for these broad reporting needs across countries. While Known CT provides much more granular clinical detail for individual patient documentation, ICD-10's strength is in its ability to efficiently aggregate and compare data at the population level for epidemiology and health statistics. LOINC is for laboratory observations, not disease classification. RxNorm handles medication naming. When you need to report causes of death or track disease prevalence nationally, ICD-10 is the efficient choice built for that purpose. 20. A medical centre implements a waterfall approach to systems development life cycle for their new patient scheduling system. What is the defining characteristic of this methodology that distinguishes it from other approaches? A. Phases overlap with continuous feedback. B. Short iterative sprints with frequent delivery. C. Phases complete sequentially with no overlap. D. User stories drive development priorities. Do you know the answer? Correct answer, C. Phases complete sequentially with no overlap. Explanation. Option C is correct because the waterfall model assumes phases can be completed sequentially with no overlap, flowing down one after another with no going back once a phase is complete. Option A is incorrect because overlapping phases with continuous feedback characterizes modified waterfall or agile approaches, not the traditional waterfall methodology, which assumes sequential completion without overlap. Option B is incorrect because short iterative sprints with frequent delivery are characteristics of agile development methodologies like Scrum, not the sequential waterfall approach to development. Option D is incorrect because user stories driving development priorities is a characteristic of agile methodologies, while waterfall assumes detailed upfront planning with sequential phase completion without iteration. Let's break down the organizational structure in Scrum methodology and clarify who does what. In traditional project management, you have project managers, team leads, and stakeholders. Scrum reorganizes these roles with specific responsibilities. The product owner is the client stakeholder, the person for whom the system is being built. They represent the business side and have the authority to make decisions about priorities and requirements. The product owner maintains the product backlog, which is that prioritized list of everything that needs to be done, and they decide what work gets pulled into each sprint based on business value. Think of the product owner as the voice of the customer with decision-making authority. The Scrum Master facilitates the process and removes obstacles but doesn't prioritize requirements. Traditional project managers don't exist in pure Scrum. That role is split between product owner and Scrum Master. The development team executes the work but doesn't maintain the backlog. Only the product owner has that stakeholder authority. 21. Clinical decision support systems can be classified using a taxonomy that examines how they function. According to the National Quality Forum Taxonomy Extension, how many main functional categories are used to classify these systems? A. 2 functional categories. B. 3 functional categories. C. 4 functional categories. D. 6 functional categories. Can you guess the answer? Correct answer, C, 4 functional categories. Explanation. Option C is correct because the National Quality Forum Taxonomy extension classifies clinical decision support systems into 4 functional categories, including triggers, input data, interventions, and action steps for comprehensive classification. Option A is incorrect because the National Quality Forum uses 4 functional categories, not 2, to provide comprehensive classification of clinical decision support systems and their capabilities. Option B is incorrect because while some classification systems use 3 categories, the National Quality Forum taxonomy specifically extends to 4 functional categories for more detailed classification of systems. Option D is incorrect because the National Quality Forum taxonomy defines exactly 4 functional categories for classification, not 6, focusing on triggers, input data, interventions, and action steps. Alright, let's explore how clinical decision support systems are organised and classified. When healthcare organisations implement CDS tools, they need a framework to understand what they're implementing and how different tools function. The National Quality Forum, working with partners healthcare researchers, developed a comprehensive taxonomy that breaks down CDS into 4 main functional categories. These 4 categories work together like a complete decision-making cycle. Triggers determine when the CDS activates, what event or condition sets it off. Input data defines what patient information feeds into the system. Interventions describe what action the CDS takes. Does it alert, suggest, or display information? And action steps specify what the clinician needs to do in response. Think of it like a smart home security system. Motion triggers it, camera data inputs, an alert sounds as intervention, and you take action. Not 2 categories, not 3, not 6. Exactly 4 functional categories that comprehensively classify how clinical decision support systems operate. 22. A healthcare organisation needs to assess whether their proposed clinical information system project is technically feasible given their current infrastructure and staff expertise. Which type of feasibility study dimension should they focus on for this assessment? A. Economic feasibility. B. Operational feasibility. C. Technology feasibility. D. Schedule feasibility. Do you know the answer? Correct answer, C. Technology feasibility. Explanation. Option C is correct because technology feasibility evaluates whether proposed technology requirements align with available infrastructure and expertise, assessing if the organisation can technically support and implement the proposed system successfully. Option A is incorrect because economic feasibility assesses financial viability and return on investment, not whether the organisation has the technical infrastructure and expertise to support the technology. Option B is incorrect because operational feasibility examines whether the organisation can operationally integrate and use the system, not specifically the technical infrastructure and expertise requirements. Option D is incorrect because schedule feasibility assesses whether project timelines are realistic and achievable, not whether the organisation has adequate technical infrastructure and staff expertise available. Let's dive into the critical planning phase of health IT projects and understand feasibility studies. Before investing resources, organisations must evaluate whether a project is viable from multiple angles: economically, operationally, technically, and timeline-wise. Technology feasibility specifically assesses whether your organisation has the technical infrastructure, hardware, software platforms, network capacity, and staff expertise to support the proposed technology. It's like asking, do we have the technical foundation and knowledge to make this work? Can our servers handle it? Do our staff have the skills? Is our network robust enough? Economic feasibility looks at return on investment and financial viability. The money question. Operational feasibility examines whether your organization can actually use and integrate the system into daily operations. Schedule feasibility assesses if timelines are realistic, but technology feasibility specifically zeroes in on that technical capability question. Infrastructure and expertise. 23. During testing phase, a healthcare system wants to ensure their new laboratory information system can handle the anticipated volume of test orders and results without performance degradation during peak periods. What type of testing should they perform? A. Unit testing. B. System testing. C. Load testing. D. Integration testing. Can you guess the answer? Correct answer, C. Load testing. Explanation: option C is correct because load and volume testing ensures hardware and software can handle anticipated clinical volumes without performance degradation, validating system capacity during peak usage periods before deployment. Option A is incorrect because unit testing validates individual components or modules in isolation, not the overall system capacity to handle high volumes during peak clinical usage. Option B is incorrect because system testing confirms that entire systems meet specified requirements, but does not specifically focus on performance under high volume conditions during peak periods. Option D is incorrect because integration testing assesses how different modules work together, but does not specifically validate system performance under anticipated volume loads during peak usage. This is about understanding the different types of testing that ensure system readiness before deployment. Testing happens in layers, each with a specific purpose. Load testing, also called volume testing, is specifically designed to validate that your system can handle the real-world demands of clinical operations without crashing or slowing down. Imagine your emergency department on a Friday night. Dozens of physicians entering orders simultaneously. Lab results flowing in. Nurses documenting care. Load testing simulates those peak conditions by throwing large volumes of transactions at the system to see if it maintains performance or if response times degrade unacceptably. It's stress testing for health IT. Unit testing validates individual code modules in isolation. System testing confirms overall functionality meets requirements, but doesn't specifically stress test capacity. Integration testing checks if components work together correctly. But when you need to verify that your laboratory information system won't buckle under thousands of test orders during peak hours, load testing is your answer. 24. A clinical informaticist is analysing how a radiology department processes imaging orders from request to report delivery. They need to understand the current state workflow to identify inefficiencies before implementing a new system. What approach should they use? A. Cost-benefit analysis. B. Risk assessment. C. Workflow analysis. D. Feasibility study. Do you know the answer? Correct answer, C. Workflow analysis. Explanation: option C is correct because workflow analysis involves observations and documentation of workflow to understand current environment processes, identify inefficiencies, and determine how workflows can be improved before system implementation. Option A is incorrect because cost-benefit analysis compares financial costs and benefits of investments, but does not examine detailed process flows and task sequences in clinical departments. Option B is incorrect because risk assessment identifies potential threats and opportunities for project success, but does not document and analyze current operational workflows and process inefficiencies. Option D is incorrect because feasibility studies broadly assess project viability across multiple dimensions, but do not provide detailed analysis of current state workflows and process inefficiencies. To really understand process improvement in healthcare, let's explore workflow analysis. Before you can improve a process, you need to understand it deeply. How does work actually flow through the department today? Where are the handoffs? Where do delays occur? Workflow analysis is the systematic approach to observing, documenting, and analysing current workflows to understand what's happening and identify opportunities for improvement. Think of it as being a detective studying the scene before solving the case. In a radiology department, you'd observe how orders come in, how technologists receive them, how images are captured and transmitted, how radiologists access and interpret them, and how reports get back to ordering physicians. You time each step, identify bottlenecks, and document inefficiencies. Cost-benefit analysis compares financial aspects but doesn't map processes. Risk assessment identifies threats but doesn't document workflows. Feasibility studies evaluate viability broadly. Only workflow analysis provides that detailed examination of current operational processes. 25. In project management, scope creep represents a significant risk to health information technology implementations. What defines this phenomenon, and why is it problematic for project success and resource management? A. Expanding project timeline without budget. B. Adding team members without justification. C. Changing project scope during implementation. D. Reducing project deliverables to save costs. Can you guess the answer? Correct answer: C. Changing project scope during implementation. Explanation: Option C is correct because scope creep refers to changes in project scope during implementation that frequently necessitate other changes, resulting in additional expenses, resources, and time beyond original plans. Option A is incorrect because expanding timelines is a consequence of scope creep, not the definition, which specifically refers to changes in what the project will deliver. Option B is incorrect because adding team members without justification is poor resource management, but scope creep specifically refers to unplanned changes, expanding what the project will deliver. Option D is incorrect because reducing deliverables is scope reduction, not scope creep, which specifically refers to unplanned expansion of project scope requiring additional resources and time. Let's break down one of the most common and problematic risks in health IT projects: scope creep. Imagine you've planned a project to implement electronic medication reconciliation. Your scope is clear, timeline is set, budget is allocated, resources are assigned. Then during implementation, someone says we should also add drug interaction checking. Then someone else says we need to integrate with the pharmacy dispensing system. Then another stakeholder wants automated allergy documentation. Suddenly your focus project has expanded into 3 or 4 projects, requiring more developers, more time, more budget, and more vendor customization. That's scope creep. Unplanned changes that expand what the project will deliver beyond the original agreed-upon scope. Each change seems reasonable in isolation, but collectively they derail projects by consuming additional expenses, resources, and time that weren't planned for. Expanding timelines is a consequence, not the definition. Adding staff is poor management. Reducing deliverables is the opposite. Scope creep specifically means the boundary of what you're building keeps expanding outward. 26. A health system is deciding between selecting individual best-in-class applications from different vendors versus implementing a fully integrated suite from a single vendor. What is a primary disadvantage of the best-of-breed approach? A. Limited functionality in specific areas. B. Single vendor dependency for support. C. Multiple complex interfaces required. D. Standardized user experience across modules. Do you know the answer? Correct answer: C. Multiple complex interfaces required. Explanation: Option C is correct because the best-of-breed approach necessitates integrating disparate systems from different vendors, leading to complex interfaces and potential compatibility issues. Option A is incorrect because limited functionality is more characteristic of a fully integrated system, which may not have the depth of functionality in specific areas that best-of-breed applications offer. Option B is incorrect because single vendor dependency is a hallmark of a fully integrated suite, not the best-of-breed approach, which by its nature involves multiple vendors. Option D is incorrect because a standardized user experience is an advantage often associated with a fully integrated suite, while the best-of-breed approach tends to present a more varied user experience due to the different systems involved. This question explores strategic decisions about how to select and implement health information systems. Healthcare organizations face a fundamental choice. Do we select the best individual product for each clinical function from different vendors? That's best of breed. Or do we get everything from one vendor in an integrated suite? Best of breed sounds attractive because you're choosing the absolute best laboratory system, the best radiology system, the best pharmacy system. But here's the major downside that trips up organizations. Each of these systems from different vendors needs to talk to each other, which requires building multiple complex interfaces. One interface to connect lab to pharmacy, another to connect radiology to the EHR, another for pharmacy to billing. These interfaces are technically challenging, expensive to build and maintain, require highly skilled specialized IT staff, and can fail, causing data to not flow. You also end up with various hardware platforms and operating systems to support. In contrast, a fully integrated system from one vendor communicates internally without custom interfaces. The interface complexity is the primary disadvantage of best of breed. 27. Clinical decision support implementation requires adherence to best practices for effectiveness. According to research, what is considered the most critical factor for clinical decision support to be accepted and used by clinicians? A. Comprehensive information requests. B. Speed of system response. C. Complex intervention algorithms. D. Mandatory user feedback. Can you guess the answer? Correct answer, B. Speed of system response. Explanation. Option B is correct because research shows that speed is everything for clinical decision support, as clinicians require rapid system responses to maintain workflow efficiency and will resist slow systems regardless of quality. Option A is incorrect because asking for additional information should only occur when really needed, not comprehensively, as excessive information requests slow workflows and reduce clinical decision support effectiveness. Option C is incorrect because simple interventions work best for clinical decision support, not complex algorithms, as complexity increases cognitive load and reduces likelihood of clinician adoption and use. Option D is incorrect because while monitoring impact and getting feedback is important, mandatory feedback requirements slow workflows, and speed is considered the most critical factor for acceptance. Let's dive into what makes clinical decision support successful in real-world clinical practice. Researchers have identified best practices for CDS implementation, and Bates and colleagues famously published the 10 Commandments for effective clinical decision support. These commandments are ranked by importance, and number one on that list is speed is everything. Here's why. Clinicians work in time-pressured environments where every second counts. If your clinical decision support tool takes 5 or 10 seconds to load drug interaction information, physicians will simply not use it. They'll bypass the check or ignore the alert because it disrupts their workflow. Speed trumps comprehensive information gathering. Speed trumps complex, sophisticated algorithms. Speed even trumps collecting additional data that might improve the recommendation. A fast, simple intervention that clinicians will actually use is infinitely more valuable than a slow, comprehensive one that gets ignored. Comprehensive information requests slow things down. Complex interventions add cognitive load. Mandatory feedback creates delays. But speed is what determines whether CDS gets used at all. 28. A healthcare organisation is planning training for their electronic health record implementation. They schedule intensive training sessions for staff just days before the system goes live. What training strategy are they employing to maximise retention? A. Super user-led training. B. Vendor tutorial training. C. Just-in-time training. D. Computer lab simulation. Do you know the answer? Correct answer, C. Just-in-time training. Explanation. Option C is correct because just-in-time training occurs close to go live, maximising retention by ensuring staff learn immediately before they need to use the system in actual clinical practice. Option A is incorrect because while super users may deliver training, the timing strategy of scheduling training close to go live is specifically called just-in-time training. Option B is incorrect because vendor tutorials refer to who delivers training content, not the timing strategy of scheduling training sessions close to system go-live date. Option D is incorrect because computer lab simulation describes the training environment and methods used, not the timing strategy of scheduling training immediately before go-live. This question is about optimizing training strategy for health IT implementations. Training timing is crucial for retention and effectiveness. If you train staff months before go-live, they'll forget what they learned by the time they need to use it. If you train too late, they'll be unprepared. Just-in-time training is the strategy of scheduling intensive training sessions immediately before the system goes live, typically within a few days to a week before staff will actually use the system. The psychology is simple. People retain information best when they can immediately apply it. It's like studying for an exam the night before versus a month before. That proximity to application enhances retention. JIT training means nurses learn the EHR documentation on Thursday and Friday, then use it for real on Monday morning when the system launches. The knowledge is fresh, muscle memory is recent, and confidence is higher. Super user-led describes who delivers training. Vendor tutorials describe the content source. Computer lab simulation describes the training method. But just-in-time specifically describes that critical timing strategy close to go-live. 29. During the analysis phase, a hospital creates documents to formally solicit vendor solutions for their new clinical documentation system. What type of document are they creating to request detailed proposals from potential vendors? A. Request for information. B. Request for proposal. C. System vision document. D. Project charter. Can you guess the answer? Correct answer, B. Request for proposal. Explanation. Option B is correct because request for proposal documents formally solicit detailed vendor solutions and proposals, allowing organizations to evaluate and compare vendor capabilities against their specific requirements during the analysis phase. Option A is incorrect because request for information gathers general information about vendor capabilities and solutions, but does not solicit detailed formal proposals for evaluation and selection. Option C is incorrect because system vision documents define scope and capabilities of new systems from the organization's perspective, not formal solicitations sent to vendors requesting proposals. Option D is incorrect because project charters formally authorize projects and outline objectives, not documents sent to vendors soliciting detailed proposals for evaluation and procurement decisions. Let's explore the procurement process during the analysis phase of health IT projects. After you've analysed your needs and requirements, you need to identify potential vendors who can meet those needs. Healthcare organisations use formal documents to solicit information and proposals from vendors. A request for proposal, or RFP, is a formal document that details your specific requirements and asks vendors to submit comprehensive proposals explaining how their solution meets your needs, what it will cost, their implementation approach, and their qualifications. RFPs are detailed and specific. You're essentially asking vendors to bid on your business by proposing a complete solution. This is different from a request for information, which is more exploratory. You're just gathering general information about what's available in the market. System vision documents define your internal requirements, not vendor solicitations. Project charters authorize projects. But RFPs are those formal procurement documents that say, we know what we need. Now tell us how you'll provide it and what it will cost. 30. A hospital implements a comprehensive clinical terminology that contains preferred terms and related synonyms, enabling detailed clinical documentation and supporting research, epidemiology, and clinical audit. Which terminology system provides this comprehensive multinational standard capability? A. LOINC, B. ICD-10-CM, C. C790 CT, D. CPT. Can you guess the answer? Correct answer, C. C790 CT. Explanation: option C is correct because C790 CT is the most comprehensive clinical terminology containing preferred terms and related synonyms, serving as an international standard supporting clinical documentation, research, epidemiology, and audit globally. Option A is incorrect because while LOINC is valuable for laboratory and clinical observations, it is not the most comprehensive clinical terminology with synonyms for all clinical documentation. Option B is incorrect because ICD-10-CM is a clinical classification system for diagnoses and procedures primarily for reimbursement, not a comprehensive terminology with preferred terms and synonyms. Option D is incorrect because CPT classifies medical procedures for billing purposes in the United States, not providing comprehensive clinical terminology with preferred terms and synonyms internationally. This is about understanding the most comprehensive clinical terminology standard in healthcare informatics. When you need to document clinical information with precision and detail, C790 CT stands alone as the gold standard. Systematized nomenclature of medicine clinical terms is the most comprehensive clinical terminology, containing over 300,000 active concepts. What makes it special is that it includes preferred terms along with related synonyms. So whether a clinician types myocardial infarction, heart attack, or MI, C790 CT recognizes them as related concepts. It's designed to support direct patient care documentation, clinical audit, research, epidemiology, and the service planning. It's become an international standard used globally. LOINC is valuable but focused specifically on laboratory tests and observations. ICD-10-CM is a classification for diagnoses used primarily for billing and reporting. CPT classifies procedures for reimbursement. But C790 CT is that comprehensive, synonym-rich terminology that enables detailed clinical documentation across all aspects of healthcare internationally. 31. In agile development using Scrum methodology, who's responsible for acting as the client stakeholder, maintaining the prioritized list of requirements, and making decisions about work to be done in upcoming sprints? A. Scrum Master, B. Product Owner, C. Project Manager, D. Development Team. Can you guess the answer? Correct answer, B. Product Owner. Explanation: option B is correct because the product owner is the client stakeholder for whom the system is being built, responsible for maintaining the product backlog and prioritizing requirements for sprint planning. Option A is incorrect because the Scrum Master is in charge of the Scrum project process and removes obstacles, but the product owner represents client interests and priorities. Option C is incorrect because traditional project managers are not part of Scrum organizational structure, which uses Scrum Masters and product owners instead for project leadership roles. Option D is incorrect because the development team executes sprint work but does not maintain the prioritized requirements list or make client stakeholder decisions about sprint priorities. Let's break down the key roles in Scrum methodology and understand who does what. Scrum has a unique organizational structure with 3 core roles, and it's important not to confuse them. The product owner is the business stakeholder, the client for whom the system is being built. They own the vision and priorities. They maintain the product backlog, which is that prioritized list of all features and requirements. They decide what goes into each sprint based on business value. Think of the product owner as the voice of the customer with decision-making authority about what gets built. The Scrum Master, in contrast, is the process facilitator who removes obstacles and ensures the team can work effectively, but doesn't make product decisions. Traditional project managers don't exist in pure Scrum. Their responsibilities are distributed between product owner and Scrum Master. The development team executes the work, but doesn't prioritize requirements. Only the product owner has that client stakeholder authority to set priorities and make decisions about what features matter most. 32. A healthcare facility needs to exchange patient assessment documents, discharge summaries, and imaging reports electronically with referring physicians and other healthcare providers. Which Health Level 7 standard should they implement for this document exchange? A. Fast Health Interoperability Resources. B. Clinical Document Architecture. C. Digital Imaging Communications. D. Logical Observation Identifiers. Do you know the answer? Correct answer, B. Clinical Document Architecture. Explanation. Option B is correct because clinical document architecture is specifically used to exchange documents such as patient assessments, discharge summaries, imaging reports, and quality reports between providers in standardized formats. Option A is incorrect because while Fast Health Interoperability Resources supports document exchange, clinical document architecture is the established standard specifically designed for clinical document exchange between providers. Option C is incorrect because digital imaging and communications in medicine is specifically for sharing digital medical images, not text-based clinical documents like assessments and summaries. Option D is incorrect because logical observation identifiers, names and codes is for laboratory and clinical observations, not for exchanging complete clinical documents between healthcare providers. This question explores health data exchange standards for clinical documents. In healthcare, providers need to exchange complete clinical documents, not just individual data elements, but full documents with context and narrative. Clinical Document Architecture, or CDA, is an HL7 standard specifically designed for this purpose. CDA provides a structured format for exchanging documents like patient assessments, discharge summaries, imaging reports, quality reports, and consultation notes between different healthcare providers and systems. Think of CDA as the standard envelope and format for clinical documents so they can be reliably transmitted and understood across different EHR systems. It ensures the receiving system can properly display and process the document. Fast Healthcare Interoperability Resources, or FHR, is broader and more modern, supporting various types of data exchange, including documents, but CDA is the established, mature standard specifically designed for clinical document exchange. DICOM is only for medical images. LOINC codes laboratory observations. When you need to send a complete discharge summary from hospital to primary care, CDA is the standard. 33. A health information technology project involves multiple aligned projects affecting many teams and departments that must be coordinated and managed together. What level of project management complexity does this represent beyond individual project management? A. Project management. B. Program management. C. Portfolio management. D. Agile management. Can you guess the answer? Correct answer, B. Program management. Explanation. Option B is correct, because program management involves larger implementations with multiple aligned projects affecting many teams or departments that are coordinated and managed in concert for comprehensive organizational change. Option A is incorrect because project management addresses individual temporary endeavors, while this scenario describes multiple coordinated projects requiring higher-level program management for alignment and integration. Option C is incorrect because portfolio management combines common programs and projects that may not be related, while program management specifically coordinates multiple related aligned projects together. Option D is incorrect because agile management refers to development methodology and philosophy, not the organizational level of coordinating multiple aligned projects affecting many teams simultaneously. To understand organizational complexity in project management, let's explore how healthcare IT initiatives scale. When you're implementing a comprehensive electronic health record across a large hospital system, you're not just managing one project, you're coordinating multiple related projects that all need to work together. Maybe you have one team implementing CPOE, another implementing clinical documentation, another handling pharmacy integration, and another managing billing system connections. These projects are all aligned toward the same goal and affect multiple departments that need coordination. This level of complexity requires program management. Programs are larger than individual projects. They involve multiple aligned projects affecting many teams that must be managed in concert to achieve organizational transformation. It's like conducting an orchestra rather than playing a solo instrument. Individual project management handles single temporary endeavors. Portfolio management is even broader, combining programs and projects that may not be related. Agile management is a methodology approach, but when you have multiple aligned projects requiring coordination across teams, you're in program management territory. 34. During health information system design, teams must ensure the system aligns with user needs and complies with regulatory requirements before development begins. Which phase encompasses creating detailed specifications, customizing vendor systems, and planning security measures? A. Planning phase. B. Analysis phase. C. Design phase. D. Testing phase. Do you know the answer? Correct answer, C. Design phase. Explanation: Option C is correct because the design phase translates specifications into concrete system configurations, including detailed functional and technical specifications, customization, prototypes, security measures, and ensuring regulatory compliance, like Americans with Disabilities Act. Option A is incorrect because the planning phase establishes project scope, objectives, stakeholder engagement, and feasibility, not the detailed specifications and system configuration developed during design. Option B is incorrect because the analysis phase examines workflows, data flows, and system needs to identify requirements, but the design phase translates those requirements into concrete configurations. Option D is incorrect because the testing phase validates system readiness through various testing methods, occurring after design specifications have been translated into actual system configurations and implementations. Let's explore the system's development lifecycle phases and understand what happens in each. The SDLC has distinct phases, each with specific deliverables. The design phase is where you take all those requirements and needs you identified during analysis and translate them into concrete specifications and configurations. This is where you develop detailed functional specifications that describe exactly what the system will do, create technical specifications for how it will be built, customize vendor systems or develop custom software applications, create prototypes for testing, plan all your hardware and software configurations, design interfaces between systems, establish security frameworks and measures, and ensure compliance with regulatory requirements like ADA accessibility standards. Think of design as translating the what into the how. Planning establishes project scope and feasibility. Analysis examines workflows and identifies requirements. Testing validates the system works. But design is that crucial phase where requirements become concrete specifications and the system architecture takes shape before actual implementation. 35. A clinical informatics nurse wants to document patient care using a standardized nursing classification system that organizes problems hierarchically and includes intervention and outcome rating schemes. Which standardized terminology should they use for community and public health documentation? A. NANDA International. B. Nursing Interventions Classification. C. Omaha System. D. Perioperative Nursing Dataset. Can you guess the answer? Correct answer, C. Omaha System. Explanation. Option C is correct because the Omaha system is designed to document nursing practice across the continuum of care, with 3 schemes including problem classification, intervention, and problem rating scale for outcomes. Option A is incorrect because NANDA International focuses specifically on nursing diagnoses, not providing the comprehensive problem classification, intervention, and outcome rating scheme of the Omaha system. Option B is incorrect because nursing interventions classification focuses specifically on nursing interventions, while Omaha system provides comprehensive problem classification, interventions, and outcome ratings together in one framework. Option D is incorrect because perioperative nursing dataset is designed specifically for perioperative nursing settings, not for community and public health documentation across the care continuum. This question is about standardized nursing terminologies designed for documenting patient care across the continuum. Different nursing terminologies were developed for different settings and purposes. The Omaha system is specifically designed to document nursing practice across the continuum of care, particularly in community and public health settings. It's unique because it provides 3 integrated schemes that work together. The problem classification scheme organizes patient health-related concerns hierarchically. The intervention scheme categorizes nursing actions. And the problem rating scale for outcomes allows you to rate patient status before and after interventions. Think of it as a complete documentation framework from assessment through intervention to outcome measurement. NANDA International focuses specifically on nursing diagnoses. The nursing interventions classification focuses on interventions only. The perioperative nursing dataset is specialized for surgical settings, not community health. But the Omaha system provides that comprehensive problem intervention outcome framework specifically designed for documenting care across community and public health settings. 36. When comparing system development methodologies, rapid application development emphasizes speed and user feedback through iterative refinement. What distinguishes this methodology from traditional waterfall approaches in healthcare information system development? A. Sequential phase completion. B. Iterative prototyping cycles. C. Detailed upfront requirements. D. Rigid planning processes. Do you know the answer? Correct answer, B. Iterative prototyping cycles. Explanation. Option B is correct because rapid application development emphasizes speed through iterative prototyping and user feedback, allowing quicker deployment and refinement based on end-user input rather than sequential phase completion. Option A is incorrect because sequential phase completion is characteristic of waterfall methodology, while rapid application development uses iterative cycles with continuous prototyping and user feedback. Option C is incorrect because detailed upfront requirements define waterfall approaches, while rapid application development allows requirements to evolve through iterative prototyping and ongoing user feedback. Option D is incorrect because rigid planning processes characterize waterfall methodology, while rapid application development embraces flexibility and adaptation through iterative development with continuous stakeholder involvement. Let's compare different software development methodologies and understand their fundamental differences. Traditional waterfall methodology assumes you can plan everything up front, execute phases sequentially, and the system emerges at the end like water flowing down steps. Once you complete a phase, you move forward and don't look back. Rapid application development takes a completely different approach. RAD emphasizes speed through iterative prototyping cycles. Instead of planning for months, you quickly build a working prototype, show it to users, get their feedback, refine it, and repeat. Users are actively involved throughout, not just at the beginning and end. This allows requirements to evolve based on hands-on experience with prototypes rather than abstract specifications. Think of our RAD like sculpting. You start with rough form and continuously refine based on feedback. Sequential phase completion is waterfall. Detailed upfront requirements define waterfall. Rigid planning characterizes waterfall, but RAD's defining characteristic is those iterative prototyping cycles with continuous user feedback, enabling rapid deployment and refinement. 37. A healthcare organization establishes a command center during their electronic health record go live to provide centralized support and rapid response to issues. This support structure is part of which systems development lifecycle phase? A. Planning phase. B. Design phase. C. Testing phase. D. Implementation phase. Can you guess the answer? Correct answer, D. Implementation phase. Explanation. Option D is correct because implementation phase involves deploying systems into routine clinical use, including establishing support structures like command centers, help desks, and superuser teams for go-live support. Option A is incorrect because planning phase establishes project scope, objectives, and feasibility, occurring before the actual system deployment and go-live support structure establishment described. Option B is incorrect because design phase translates specifications into system configurations and prototypes, not deploying systems or establishing go-live support structures like command centers. Option C is incorrect because testing phase validates system readiness before deployment through various testing methods, not establishing go-live support structures for actual clinical implementation. This question explores the support infrastructure needed during health IT go-live. The implementation phase is when the system actually goes live and staff begin using it in real clinical operations. This is the highest risk period where problems can impact patient care. To manage this risk, organizations establish robust support structures. A command center is a centralized location, often a conference room, where key leaders, IT staff, trainers, clinical leaders, and vendor representatives gather during go-live. It serves as mission control. Issues are reported to the command center, decisions are made quickly, resources are deployed to problem areas, and communication is coordinated. Think of it like an emergency operations center during a crisis. Along with help desks and super user support, the command center ensures rapid response to issues. Planning phase happens before deployment. Design phase creates specifications. Testing phase validates before go-live. But the implementation phase is when you deploy the system into clinical use and establish those critical support structures like command centers. 38. The project management body of knowledge defines a knowledge area focused on comparing costs and benefits, calculating internal analyses, and monitoring expenditures as projects progress. Which knowledge area encompasses these financial management responsibilities? A. Project scope management. B. Project time management. C. Project cost management. D. Project quality management. Do you know the answer? Correct answer, C. Project cost management. Explanation. Option C is correct because project cost management involves calculating internal cost-benefit analysis and updates, monitoring expenditures as projects progress, and managing resources including materials, equipment, facilities, and labour costs. Option A is incorrect because project scope management defines and controls functions included in systems and work scope, not financial calculations and expenditure monitoring throughout projects. Option B is incorrect because project time management creates detailed schedules and monitors progress against milestones, not managing costs, budgets, and financial expenditures during project execution. Option D is incorrect because project quality management establishes comprehensive plans for ensuring quality deliverables through quality assurance and control, not financial cost monitoring and management. Let's explore the 10 knowledge areas in PMBOK and understand what each one encompasses. The project management body of knowledge organizes project management into 10 distinct areas, each focusing on different aspects of project execution. Project cost management is the knowledge area specifically dedicated to financial aspects of the project. This includes calculating internal cost-benefit analyses to justify the project initially, monitoring and controlling expenditures as work progresses to ensure you stay within budget, managing resources like materials, equipment, facilities, and labour costs, forecasting future costs, and providing financial reporting to stakeholders. Think of cost management as being the project's CFO. Everything related to money flows through this knowledge area. Project scope management defines what work is in or out but doesn't handle budgets. Project time management schedules work but doesn't track dollars. Project quality management ensures deliverable standards but doesn't manage financial resources. Cost management is specifically about the money, tracking it, controlling it, and reporting it throughout the project lifecycle. 39. A hospital pharmacy implements closed-loop barcode medication. Administration integrated with their electronic health record to prevent medication errors. This safety technology addresses which common source of preventable medical errors in healthcare? A. Diagnostic errors. B. Medication errors. C. Surgical errors. D. Communication errors. Can you guess the answer? Correct answer, B. Medication errors. Explanation, option B is correct because electronic health records integrated with closed-loop bedside barcode medication administration specifically reduce medication errors by verifying correct patient, drug, dose, route, and time before administration occurs. Option A is incorrect because while electronic health records support clinical decision-making, closed-loop barcode medication administration specifically targets medication errors, not diagnostic errors in clinical reasoning. Option C is incorrect because barcode medication administration verifies medication administration accuracy, not surgical procedures, which require different safety protocols and verification processes for error prevention. Option D is incorrect because while health information technology improves communication, barcode medication administration specifically prevents medication administration errors through technology-enabled verification at the point of care. This question addresses a critical patient safety issue in healthcare and how technology helps prevent it. Preventable medical errors are one of the leading causes of death, and medication errors represent a significant portion of these preventable mistakes. Electronic health records integrated with closed-loop barcode medication administration create a powerful safety net. Here's how it works. When a nurse is about to give a medication, they scan the barcode on the patient's wristband to verify identity, then scan the medication barcode. The system checks in real time. Right patient, right drug, right dose, right route, right time. The 5 rights of medication administration. If anything doesn't match, the system alerts the nurse before the medication is given. The closed loop part means the administration is documented immediately, closing the loop from order to administration. This dramatically reduces medication errors. While EHRs support clinical decision-making for diagnoses, barcode medication administration specifically targets medication errors. It doesn't prevent surgical errors or general communication failures. It's laser focused on medication safety. 40. During requirements gathering, a healthcare organisation identifies that clinicians need immediate access to patient-specific reference information and clinical guidelines at the point of care. What type of clinical decision support tool provides seamless access to these resources? A. Drug interaction alerts. B. Duplicate therapy warnings. C. Info buttons. D. Workflow reminders. Do you know the answer? Correct answer, C. Info buttons. Explanation: option C is correct because info buttons enable seamless access to patient-specific reference information and knowledge resources within electronic health records, reducing barriers to using clinical guidelines and evidence at point of care. Option A is incorrect because drug interaction alerts warn about medication conflicts, but do not provide seamless access to comprehensive patient-specific reference information and clinical guidelines embedded in workflows. Option B is incorrect because duplicate therapy warnings alert prescribers about redundant medications, but do not provide access to broader reference information and clinical guidelines for decision support. Option D is incorrect because workflow reminders prompt clinicians about care needs like immunizations, but do not provide comprehensive access to patient-specific reference information and knowledge resources. Let's explore a specific type of clinical decision support tool that addresses information access at the point of care. Clinicians need access to medical knowledge and guidelines while they're seeing patients, but opening separate applications or searching websites disrupts workflow. Info buttons solve this problem elegantly. An info button is a context-aware link embedded directly in the EHR that, when clicked, automatically searches relevant knowledge resources based on the patient's specific data and the clinical context. For example, if a physician is reviewing a patient's lab results showing elevated liver enzymes, clicking the info button next to that result could automatically pull up clinical guidelines about evaluating hepatic dysfunction, specific to this patient's age, gender, and other relevant factors. The key is it's patient-specific and context-aware, not generic searches. Drug interaction alerts warn about medication conflicts. Duplicate therapy warnings identify redundant prescriptions. Workflow reminders prompt about care needs. But info buttons provide that seamless, context-aware access to knowledge resources embedded right in the clinical workflow. 41. A regional health system wants to coordinate the use of established health information technology standards across their network to improve interoperability. Which organisation specifically promotes coordinated use of existing standards rather than developing new ones? A. Health Level 7, International. B. International Organisation for Standardisation. C. Integrating the Healthcare Enterprise. D. Institute of Electrical and Electronics Engineers. Can you guess the answer? Correct answer, C. Integrating the Healthcare Enterprise. Explanation: option C is correct because Integrating the Healthcare Enterprise International promotes the coordinated use of established standards in health information technology to improve interoperability rather than developing new standards from scratch. Option A is incorrect because Health Level 7 International develops new standards frameworks like fast health interoperability resources and clinical document architecture, not just coordinating existing standards. Option B is incorrect because International Organisation for Standardisation develops international standards working with national standards bodies, not specifically coordinating use of existing health information technology standards. Option D is incorrect because Institute of Electrical and Electronics Engineers develops industry standards in broad technology ranges, not specifically coordinating existing healthcare interoperability standards for implementation. Let's explore the landscape of healthcare standards organizations and understand their different roles. When it comes to health information technology, multiple organizations develop and coordinate standards. Some organizations create new standards from scratch, while others focus on coordinating the use of existing standards. Integrating the Healthcare Enterprise, or IHE International, takes a unique approach. Rather than developing new standards, IHE promotes the coordinated use of established standards that already exist. Think of IHE as the conductor, making sure all the different instruments, the existing standards, play together harmoniously. They develop integration profiles that show how to use HL7, DICOM, and other standards together in specific clinical scenarios. Health Level 7 International actually develops new framework standards like FHI and CDA. The International Organization for Standardization develops international standards through national bodies. IEEE develops broad technology standards. But IHE specifically coordinates existing standards rather than creating new ones, ensuring they work together in practice. 42. A healthcare organization needs to minimize disruption during their new system deployment by running both old and new information systems simultaneously until staff are comfortable with the transition. What implementation approach should they use? A. Phased implementation. B. Big Bang implementation. C. Parallel implementation. D. Waterfall implementation. Do you know the answer? Correct answer, C. Parallel implementation. Explanation. Option C is correct because parallel implementation runs old and new systems concurrently until full transition is complete, allowing organizations to maintain operations while staff adapt to new systems gradually. Option A is incorrect because phased implementation involves incremental rollout to different units sequentially, not running both old and new systems simultaneously during the transition period. Option B is incorrect because Big Bang implementation deploys new systems simultaneously across all units at once, discontinuing old systems immediately rather than running both concurrently. Option D is incorrect because waterfall implementation is a sequential development methodology approach, not a deployment strategy for managing transition from old to new systems. This question explores implementation strategies and how to minimize disruption during major system transitions. When deploying a new health IT system, organizations face the critical decision of when to turn off the old system. Some organizations choose Big Bang where the old system stops and new system starts simultaneously. Others choose phased implementation, rolling out gradually by location. But when risk tolerance is very low and you want maximum safety, parallel implementation is the answer. In parallel implementation, you run both the old system and the new system simultaneously for a period of time, maybe weeks or months. Staff document in both systems. This doubles the work temporarily, but it provides a safety net. If the new system has problems, the old system is still running, and patient care isn't disrupted. Once you're confident the new system is stable and staff are comfortable, you discontinue the old system. It's like keeping your old car while test driving the new one. Phased rolls out by location. Big Bang switches immediately. Waterfall is a development methodology, not deployment. Parallel runs both systems concurrently. 43. In clinical terminology standards, the American Health Information Management Association developed a model to assess coding applications and data quality. How many characteristics does this data quality management model define for monitoring data across different domains? A. 5 characteristics. B. 8 characteristics. C. 10 characteristics. D. 12 characteristics. Can you guess the answer? Correct answer, C. 10 characteristics. Explanation. Option C is correct because the American Health Information Management Association Data Quality Management Model defines 10 characteristics to monitor data quality, including accessibility, accuracy, comprehensiveness, consistency, currency, definition, granularity, precision, relevancy, and timeliness. Option A is incorrect because the data quality management model encompasses 10 characteristics, not 5, to provide a comprehensive assessment of data quality across all relevant dimensions. Option B is incorrect because while 8 is close, the model specifically defines 10 distinct characteristics to monitor data quality comprehensively across the 4 different domains. Option D is incorrect because the data quality management model defines exactly 10 characteristics for monitoring data quality, not 12, covering essential dimensions from accessibility to timeliness. Let's dive into how we evaluate data quality in healthcare informatics. The American Health Information Management Association developed the data quality management model specifically to assess the quality of healthcare data systematically. This model is comprehensive because it defines 10 distinct characteristics that need to be monitored across 4 different domains. These 10 characteristics are: accessibility, can authorized users get to the data? Accuracy, is the data correct and free from errors? Comprehensiveness, is all necessary data captured? Consistency, is data uniform across systems and time? Currency, is data up to date and current? Definition, are terms and data elements clearly defined? Granularity, is data detailed enough for its intended use? Precision, how exact and specific is the data? Relevancy, is the data applicable to the decision at hand? And timeliness, is data available when needed? Together, these 10 dimensions provide a complete framework for evaluating healthcare data quality. Not 5 characteristics, not 8, not 12. Exactly 10 characteristics that comprehensively cover data quality assessment. 44. A clinical research team wants to identify patterns in large healthcare datasets using statistical analysis, machine learning methods, and data visualization. What informatics approach are they employing to discover knowledge from their data? A. Data mining. B. Gap analysis. C. Workflow analysis. D. Cost-benefit analysis. Do you know the answer? Correct answer, A. Data mining. Explanation: option A is correct because data mining entails methods such as statistical analysis, machine learning, and data visualization to identify patterns in large datasets and discover knowledge from data. Option B is incorrect because gap analysis identifies discrepancies between current capabilities and future needs, not identifying patterns in large datasets using statistical and machine learning methods. Option C is incorrect because workflow analysis examines process flows and task sequences to identify inefficiencies, not discovering patterns in large datasets through statistical analysis and machine learning. Option D is incorrect because cost-benefit analysis compares financial costs and benefits of investments, not identifying patterns in large datasets using machine learning and data visualization techniques. This question is about advanced analytics in healthcare informatics. As healthcare organizations accumulate massive amounts of data in their electronic systems, they need sophisticated methods to extract meaningful insights from all that information. Data mining, also called knowledge discovery, and data mining, or KDDM, is the approach that uses statistical analysis, machine learning methods, and data visualization to identify patterns in large datasets. Think of it like being a detective sifting through mountains of clues to find hidden patterns. For example, data mining might discover that patients with a specific combination of lab values, medications, and demographics have high readmission rates. A pattern not obvious without analyzing thousands of patient records. It uses techniques from statistics, artificial intelligence, and computer science to find relationships and predict outcomes. Gap analysis identifies functional differences, but doesn't mine large datasets. Workflow analysis examines processes. Cost-benefit analysis compares financials, but data mining specifically refers to sophisticated analysis of large datasets to discover knowledge and patterns using machine learning and statistical techniques. 45. During project initiation, a team develops a document that defines the scope of a new clinical system by listing required capabilities, describing problems to solve, and outlining business benefits. What is this foundational document called? A. Project Charter. B. System Vision Document. C. Functional Specification. D. Request for Proposal. Can you guess the answer? Correct answer, B. System Vision Document. Explanation: option B is correct because system vision documents help define the scope of new systems through components, including problem description, business benefits, and system capabilities, providing a foundational definition for project initiation. Option A is incorrect because while project charters formally authorize projects, system vision documents specifically define the scope through problem description, business benefits, and system capabilities during early planning. Option C is incorrect because functional specifications detail technical system requirements and features, while system vision documents provide a higher level scope definition with problems, benefits, and capabilities. Option D is incorrect because requests for proposals solicit vendor solutions based on requirements, while system vision documents define the internal understanding of problems, benefits, and needed capabilities. Let's explore foundational planning documents in health IT projects. At the very beginning of a project, before you have detailed requirements or specifications, you need to establish what problem you're solving and why the project matters. The system vision document serves this foundational purpose by capturing three essential components. First, it includes a problem description that clearly articulates what's wrong with the current state and why change is needed. Second, it outlines the business benefits. What value will this new system bring to the organization, usually measured in terms like improved efficiency, reduced costs, better patient outcomes, or competitive advantage? Third, it lists the system capabilities, the high-level functions and features the new system needs to have to solve the problems and deliver those benefits. Together, these three components define the project's scope and purpose at a conceptual level before you dive into technical details. Project charters formally authorize projects with timelines and budgets. Functional specifications detail technical requirements. RFPs solicit vendor proposals, but system vision documents provide that early conceptual scope definition. 46. A healthcare quality team implements clinical decision support that displays intensive care daily reports and disease management dashboards to help clinicians quickly understand patient status. What category of clinical decision support does this represent? A. Alerting systems. B. Expert systems. C. Relevant information display. D. Workflow reminders. Do you know the answer? Correct answer, C. Relevant information display. Explanation: option C is correct because relevant information display provides seamless access to patient information or summarizes prominent aspects of records like intensive care reports and disease management dashboards, helping clinicians understand conditions. Option A is incorrect because alerting systems notify clinicians about specific care needs or risks like drug interactions, not displaying summarized information views of patient status. Option B is incorrect because expert systems provide diagnostic or therapeutic advice based on patient parameters, not displaying summarized patient information for clinician review and understanding. Option D is incorrect because workflow reminders prompt about specific care actions needed, while relevant information display summarizes patient status through reports and dashboards for clinician assessment. Let's break down different categories of clinical decision support and understand their specific purposes. Clinical decision support tools serve various functions at the point of care. Some provide alerts and warnings. Others give expert recommendations. But one important category focuses on displaying information in ways that help clinicians understand patient status quickly. Relevant information display tools provide seamless access to patient information or summarize prominent aspects of the medical record to help clinicians grasp the patient's conditions and status efficiently. Examples include intensive care daily reports that summarize all critical information for ICU patients on a single screen, or disease management dashboards that show key metrics for diabetic or heart failure patients. These aren't alerting about problems or recommending specific actions. They're organizing and presenting information so clinicians can make informed decisions. Alerting systems warn about specific issues like drug interactions. Expert systems provide diagnostic or therapeutic advice. Workflow reminders prompt about care actions. But relevant information display summarizes and presents patient data for clinical understanding. 47. The Institute of Medicine recommends that federal agencies have authority to require health information technology vendors to register products and report negative events. What's the primary safety goal of this recommendation for monitoring technology? A. Increase vendor competition. B. Monitor safety issues. C. Reduce implementation costs. D. Improve user training. Can you guess the answer? Correct answer, B. Monitor safety issues. Explanation: Option B is correct, because the recommendation aims to establish mandatory information technology safety criteria and publish annual safety reports by monitoring safety issues and negative events. Option A is incorrect because while vendor registration provides transparency, the primary goal is monitoring safety issues and negative events, not increasing competition among health information technology vendors. Option C is incorrect because vendor registration and safety event reporting focus on patient safety monitoring and risk identification, not reducing costs of implementing health information technology systems. Option D is incorrect because while safety monitoring may inform training, the primary goal is identifying and addressing safety issues through mandatory event reporting, not improving user training programs. This question addresses federal oversight of health information technology safety. The Institute of Medicine, now called the National Academy of Medicine, recognized that health IT can introduce new types of risks and errors. They made recommendations for how federal agencies should oversee and monitor health IT safety. The IOM specifically recommended that federal agencies should have authority to require IT vendors to register their products with the government and communicate negative events or safety issues associated with their applications. Think of it like the FDA's oversight of medical devices. The idea is that when problems occur with health IT systems, there should be mandatory reporting so patterns can be identified and addressed. The recommendations also included establishing mandatory IT safety criteria that vendors must meet and publishing annual reports on identified safety issues and mitigation strategies. The primary goal is monitoring safety issues and protecting patients. While vendor transparency might increase competition as a side effect, that's not the primary safety goal. Reducing costs isn't the focus. Training improvements might result but aren't the main objective. Safety monitoring and patient protection are the core purposes. 48. A hospital project team wants to identify which project tasks are essential and directly determine the overall project duration. Which project management tool should they use to analyze task dependencies and timelines? A. Work breakdown structure. B. RACI matrix. C. Gantt chart. D. Critical path method. Do you know the answer? Correct answer, D. Critical path method. Explanation: Option D is correct because critical path method identifies essential tasks that directly determine project duration by analysing dependencies and timelines, helping teams focus on activities that impact overall schedule most significantly. Option A is incorrect because work breakdown structures decompose project scope into work packages hierarchically, but do not analyse which specific tasks determine overall project duration through dependencies. Option B is incorrect because RACI matrices assign task responsibilities and clarify accountability, but do not identify which tasks are essential for determining overall project completion timelines. Option C is incorrect because while Gantt charts display timelines and dependencies visually, critical path method specifically analyses which tasks are essential for determining overall project duration. Let's explore advanced project management techniques for optimizing project schedules. When managing complex health IT projects with hundreds of interdependent tasks, you need to identify which tasks are absolutely critical to completing the project on time. The critical path method is a scheduling technique that analyzes task dependencies and durations to identify the sequence of tasks that directly determine the project's overall duration. This sequence is called the critical path. Any delay in a critical path task delays the entire project. Tasks not on the critical path have slack or float time. They can be delayed without affecting the project's end date. Understanding your critical path helps you focus resources and attention on the tasks that truly matter for on-time delivery. It's like identifying the bottleneck in a production line. Work breakdown structure organizes tasks hierarchically, but doesn't identify which ones control the schedule. RACI matrix assigns responsibilities. Gantt charts visualize timelines. But critical path method specifically analyzes dependencies to determine which tasks are essential for project duration. 49. A healthcare organisation implements meaningful use standards for their electronic health record to demonstrate effective use for quality improvement and qualify for incentive payments. Which federal legislation established these meaningful use requirements and incentives? A. Hyper-Security Rule. B. Americans with Disabilities Act. C. High-Tech Act. D. Affordable Care Act. Can you guess the answer? Correct answer, C. High-Tech Act. Explanation: option C is correct because the Health Information Technology for Economic and Clinical Health Act, known as High-Tech, promoted health information technology adoption through meaningful use standards and established incentive programs for qualified use. Option A is incorrect because HIPAA security rule focuses on protecting confidentiality and security of health information, not establishing meaningful use standards and incentive payments for adoption. Option B is incorrect because Americans with Disabilities Act establishes accessibility standards for persons with disabilities, not meaningful use standards, and incentives for health information technology adoption. Option D is incorrect because while the Affordable Care Act addressed healthcare delivery, High-Tech Act specifically established meaningful use standards and incentive programs for electronic health record adoption. This question is about understanding the federal legislation that transformed health IT adoption in the United States. In the late 2000s, electronic health record adoption was low and progress was slow. The government recognized that health IT could improve quality, safety, and efficiency, but needed incentives to drive adoption. The Health Information Technology for Economic and Clinical Health Act, known as High-Tech, was passed as part of the American Recovery and Reinvestment Act in 2009. High-Tech did several things. It provided billions of dollars in incentive payments to hospitals and physicians who adopted certified EHR systems. It established the Meaningful Use Program that defined what qualified as effective use of health IT for quality improvement. It promoted health information exchange, and it strengthened HIPAA privacy and security provisions. This legislation fundamentally changed the landscape, accelerating EHR adoption across the country. HIPAA security rule focuses on data protection, not adoption incentives. ADA addresses accessibility. Affordable Care Act addressed insurance coverage, but high-tech specifically established meaningful use standards and incentives for health IT adoption. 50. In Agile development, a team maintains a prioritized list of all outstanding user requirements and feature requests that guides sprint planning and work selection. What is this prioritized list called in Scrum methodology? A. Sprint backlog. B. Product backlog. C. System vision. D. Work breakdown structure. Do you know the answer? Correct answer, B. Product backlog. Explanation: option B is correct because the product backlog is the prioritized list of user requirements maintained by the product owner, used to choose work to be completed in each sprint throughout Agile projects. Option A is incorrect because the sprint backlog contains work selected for a specific sprint, while the product backlog is the comprehensive prioritized list of all requirements across the project. Option C is incorrect because the system vision defines high-level scope and objectives, while the product backlog is the detailed prioritized list of user requirements for sprint planning. Option D is incorrect because the work breakdown structure hierarchically decomposes project scope in traditional project management, while the product backlog is the agile prioritized requirements list for sprints. Let's wrap up by understanding how Agile teams manage their work and maintain priorities. In Scrum methodology, all the work that needs to be done, all features, enhancements, bug fixes, technical debt, is captured in one central place. The product backlog is that comprehensive prioritized list of all user requirements and work items for the entire product. It's maintained by the product owner, who continuously prioritizes items based on business value, with the highest priority items at the top. During sprint planning, the team selects items from the top of the product backlog to work on in the upcoming sprint. As new needs emerge, they're added to the product backlog and prioritized against existing items. Think of it as a living to-do list for the product that evolves throughout the project. The sprint backlog is different. It contains only the specific work selected for the current sprint. System vision is the high-level concept. Work breakdown structure is used in traditional project management, but in Scrum, the product backlog is that master prioritized list that guides all sprint planning. You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.